Okay, hello. My master student Tania could not escape her TAing duties for chemistry department, and I could escape my class, so I'm presenting today. We have been interested in using ultrasound for release of hormones, and specifically here for applying ultrasound on beta cells and pancreas. Potential treatment would be type 2 diabetes here. I saw this for the first time at ISTU in 2005. A Japanese group showed applying ultrasound on fat cells, and they got leptin out, and I found that very interesting. We have been working on this for the last several years. So there are a lot of people with type 2 diabetes. The treatment is pharmacological. There are unwanted effects with pharmacological treatments. There is no pharmacological treatment out there. We just want to see whether ultrasound may be an option for that. There are a lot of challenges, as you can see. And I'm going to show that soon. So therapeutic ultrasound has been shown to induce calcium influx in various cell types, including fibroblasts, neurons, and chondrocytes, among others. And insulin release from beta cells is calcium-dependent mechanisms. And I'm going to show a little bit about that too. So our hypothesis is that low-intensity therapeutic ultrasound may be used for non-invasive treatment for early stages of type 2 diabetes where beta cells, while beta cells are still present in the patient. In later stages, they go away, and then you end up injecting insulin. First, I'm going to show a few slides on our in vitro studies. We did several types of in vitro studies. Okay, this is one setup. We had another setup in a petri dish. We tested different frequencies to see what kills the cells, what keeps them alive. 800 kilohertz, 1 megahertz. We were able to get them to stay alive and to get insulin out. We tested with trypan blue, and then we followed up with MDT cytotoxicity assay, and they stayed alive. So of course, this is in vitro, so the question was always, oh, maybe you kill a few cells and you get insulin out. So we were not, now the next step was to see what are the mechanisms. We did calcium imaging. I'm not going to show that here, but we also tested whether calcium is important by introducing extracellular chelator, EGTA, and I'm going to show that data is here. If we add EGTA to the in vitro setup, we don't release insulin. Another study that we were kind of interested in is, can you see real-time effects of ultrasound? And now you cannot do amperometry on insulin itself, but you can do like a mimic of dopamine that you put in insulin vesicles. And we did that with loaded beta cells with dopamine. And when we apply ultrasound, you can see the release. Now we applied EGTA here, you see less of release. Now the next step was, of course, this is in vitro. Can you do this in vivo? And it took like 7 months to grow the diabetic model. And then we applied like simple non-invasive ultrasound on it, 1 megahertz, 1 watts per centimeter square. We did terminal and survival studies. We only managed to analyze the terminal so far, so I'm going to show you some of our data, but I can tell you after the treatment, the mice were doing just fine for that 8 weeks, so we didn't see any gross adverse effects due to ultrasound application. Treatment protocol, get the blood, apply ultrasound, and then test for insulin and glucose at 5 minutes and at 35 minutes. And what you can see here is the treatment, and there is no skin burn. We're still working on histology. Now, it looks like we can get insulin out, and this is in the blood, in the live mouse. So we got statistical significance here. However, glucose, we did the glucose monitor, and it's inconclusive. Variability is high, but we still have our survival data to analyze, and there may be hope there. We also got some a small grant to analyze how this could potentially be applied on patients, and this was the National Children's Medical Center, so specifically adolescent patients. So we got CT scans of normal-sized adolescents and obese adolescents. We have been struggling this year to try to do modeling. Can we reach the pancreas? If this is to be used in a human, can it be used at all, or it has to be an implantable transducer and so on? Doing a full model of a CT and running the modeling is turning out to be difficult because it takes forever. So we try to simplify the model, but we are trying to go back to the complex model too, of course. Now, if you're doing the ultrasound imaging of the pancreas, sometimes you have to fill the stomach with water and so on. So we are trying to see, is there a way, maybe if the stomach is filled with water, can the pancreas be reached? Now, what's the impact of fat? And we are still working on that. Now, this is even more difficult than that. Okay, so let's put the humans aside. Let's just stick to the mice. The other things we need to test is, are we releasing the digestive hormones, the digestive enzymes at the same time, and glucagon that's opposing insulin, and that's something that we have to look into. It may happen that ultrasound application will release both insulin and glucagon, but there is a possibility for this to be optimized because there are feedbacks between these two hormones. We are not there yet. Okay, that's it. Thank you.
Thank you. Do we have any questions out there? I have a quick question. How are you going to control, assuming you can actually get this to work, how are you going to control the quantity of insulin released? How do you, it's essentially a dose question, right?
Yeah, the dose question is difficult. So that will have to be tested in a human, in a controlled manner. Yes.
Yeah, so type 2 diabetes is generally characterized by systemic insulin resistance. Insulin availability isn't always a problem, and when it is, it's not difficult to administer endogenous insulin. So I wonder if you could talk a little bit about what this treatment protocol offers over just injectable insulin, say, or ingestible.
It's like we actually did interviews with patients for the ICOR program, and there is a subgroup of patients that would prefer their body producing their own insulin as composed to injections and other stuff. But yeah, this would be mimicking a subgroup of medication that just promotes insulin release from beta cells.
Yep. Thank you.
Okay. Thank you.
Thank you very much.